Afternoon once again, and first of all let me thank Dr. Reema for making me a part of this wonderful instruction course, and also to Dr. Vishali and all the course speakers and instructors in this course, and to AIOS again for giving us a chance to talk about this. Now the beauty about uveitis is that in a lot of these cases a good meticulous clinical examination and history can help us in coming to a diagnosis. You do not necessarily have to resort to extensive lab investigations like what is commonly thought. People confuse uveitis by saying that you need extensive lab investigations. But the point is that the foundation of diagnosing uveitis is based upon a good history taking and a meticulous clinical evaluation. And if you do that, a lot of times you will be able to arrive at diagnosis without resorting to extensive investigations. So like I said, take a meticulous history and always check the fellow eye. And let me show you a few examples. So this was a patient who presented to the clinics with this retinitis lesion over here, one more sclerosed vessel. Somebody had initially thought of this to be a post-fever retinitis, but then the mistake which they did was they did not look at the other eye. Now this is a unifocal retinitis, and while your differentials may include toxoplasmosis, post-fever retinitis and whatever else you might think, the moment you cast a look at the other eye, your diagnosis becomes absolutely straightforward. This is what the other eye had. You had a healed toxoplasmosis scar. So you have a healed scar in one eye, you have a retinitis in the other eye, you already know that you are dealing with a toxoplasmosis lesion. We treated the patient with Bacterium DS, patient's lesion healed immediately. So the point is, if you had looked at the other eye, you would not even have had a confusion about what you're dealing with. Another case, this was a known case of non-Hodgkin's lymphoma presented to our clinics with no PL vision, 60-year-old lady with a decreased vision for the last 2 months. Now this is the left eye where most of the retinal details are obscured by the extensive vitritis and the opacities which you have. But if you look at this other eye, you see this lesion over here, you see this blood hemorrhages, you see this retinitis lesion. This is already a known case of non-Hodgkin's lymphoma. Patient is immunosuppressed, you see these retinitis lesions with hemorrhages, and your diagnosis probably becomes clear. You are probably dealing with a viral component, a CMV retinitis. We went ahead, did a vitrectomy, took a biopsy. The reason we took a biopsy was because sometimes in these cases even an intraocular lymphoma can present like this, rarely. But the point is the biopsy came positive, the PCR came positive for CMV. But again, looking at the other eye gives us a clue to what we are dealing with. So while the left eye vision or the features may be obscured by the vitritis, looking at the right eye shows you this clear viral retinitis picture. This was a patient with CMV retinitis, was treated with intravitreal ganciclovir initially and subsequently oral valganciclovir. And subsequent to that, the lesion started regressing. You can't do much about the left eye. There is already optic nerve infiltration and these extensive hemorrhages and damage to the retina. But the right eye vision was salvaged. Until the last follow-up, she was maintaining a visual acuity of 20/20. This is the third case. This patient again came to a clinic with extensive, these multiple miliary lesions which were obscured a little bit by the vitritis, but these miliary lesions in itself had given us a clue to probably what we are looking at. We thought that we are dealing with ocular syphilis because that presents with these multiple miliary lesions. But the right eye, looking at the right eye, absolutely confirmed our diagnosis. You see this area of vasculitis and you see these multiple miliary lesions. And OCT through these lesions subsequently showed us the presence of this full thickness involvement of retina, a finding which we had earlier described as characteristic of ocular syphilis. So again, looking at both eyes makes our job easier, gives us an opportunity to look at much more clinical details which we are seeing, and also helps us in basically looking for subtle clues which might be obscured in the eye which you are seeing initially. This is the fourth case. Again, I am just showing you clinical examples to illustrate upon the fact that why is it important to check both the eyes. And this is a patient who presented with this extensive vasculitis in the left eye, but the other eye showed this area of subvascular pigmentation, a sign which is often associated with tuberculosis. We investigated the patient came out to be positive for ocular tuberculosis and was treated on lines of TB vasculitis, and the patient did end up doing well. This is another case. This was a patient who came with this choroiditis lesions in the eye, and you can see these multiple separate choroiditis lesions in the right eye, but the left eye, you see the left eye and you can see this serpiginous like choroiditis lesion, which is classic clinical presentation. Again, patient was MON2 positive, treated on lines of serpiginous like choroiditis, and then the lesions regress. This is one more patient. Now this was a patient who presented with this extensive lesion, and what you have to think is, why does the other eye hold importance? And this is one classical case. This was a patient who came with extensive scarring, this hemorrhage over here, and some details are obscured by the cataractus changes, but you can see these extensive changes in the left eye. You can see this peripheral lesion over here again in the left eye, and initially was thought of as uveitis, was investigated. The patient's OCT revealed this area of scarring and cystoid changes over here, but look at the right eye. The right eye is absolutely normal, and what you see are these pachychoroid vessels. What you were seeing earlier was not a uveitis, not any choroidal inflammation, but was subretinal heme in a case of polypoidal choroidal vasculopathy. So this patient had PCV. You see these pachychoroid vessels in the OCT, which again help us in arriving at a diagnosis and overcoming the confounded features which you may see otherwise. So with these examples, I will conclude my talk and come back to the point. Always make it a habit to check both the eyes. The other eye will often give you small subtle clues which will help you in arriving at a diagnosis and which will make your job easier. And as clinicians, it's our duty anyways to look at both eyes. Thank you so much.
So thank you, Mudit. Any questions? I would also like to highlight that even if the other eye is asymptomatic, we must dilate and see, because many times we get these tubercular, perivascular choroiditis scars just in the other eye, or some kind of pigmentation. And
yeah, that is what we had in the other case, the one where we had that vasculitis lesion, the other eye. Otherwise, the patient was 22. Okay. Even though the vision was 20/20 in the other eye, the periphery revealed those subvascular changes, which helped us in basically realizing what we are dealing with. The same holds true for the last case which I had shown. The patient was 20/20 in the right eye, but an OCT through that area showed us pachychoroid and then made us realize that we are not dealing with any inflammation, but we were dealing actually with a polypoidal choroidal vasculopathy. And those was peripheral hemorrhages which we were seeing and not any choroidal lesion.
so, thank you, Mudit. We move on to the IUSG symposium.
You want to discuss? You're welcome.
नहीं, Dr. Bis, अभी आपका है.
One question. Absolutely.
Sir, in the second case, which eye did you do vitrectomy? Sir, right eye or the left eye?
No, we did a vitrectomy from the left eye.
The no PLI.
Yeah.
So can we do some intraocular procedure in the no PLI? Is it?
Intraocular procedure as in a coloretinal biopsy?
No, vitrectomy. Anything.
Yeah, you can. You are doing a diagnostic vitrectomy. You see extensive vitritis, you see those cells in the eye. All you need to do is go and take a sample. I would be, if both the eyes have got signs of inflammation, I would probably be more comfortable in taking the sample from an eye which is anyways no PL. Yes. The reason you are doing a vitrectomy is basically to arrive at a diagnosis.
Okay, sir.
Yeah.
So what is important is that you take the consent of the patient and you explain, you counsel the patient accordingly, that you're doing just for the benefit of diagnosis and not for improving the vision.
Yeah. So you have to explain that this is not a therapeutic intervention, this is a diagnostic intervention.
And it's always better to do it in the worse eye, because diagnostic vitrectomy in the right eye, if it develops detachment, God forbid, so that's the seeing eye. So when you are performing diagnostic interventions, always choose the worse eye. Okay.
Yeah. Even in eyes where we are suspecting a tumor in both eyes, or where you need to take a chorioretinal biopsy, again like what ma'am said, it makes sense to go and take a biopsy from the non-seeing eye or from the worst eye. You want to preserve the good eye. So it makes sense for you to take a specimen from the other eye.